Okay, I'm sitting here with Rodrigo Scattone, and we, I think we got on a phone call about a month ago talking about tendons, what we're going to talk about here, and some interesting things about kinetic chain, the loading tiers, and quad tendinopathy. I'm just trying to get different things on the podcast that maybe I haven't heard, and we talked about some pretty interesting things. So, why don't you tell everyone who you are?
Sure. Thanks for having me, Jake. It's a pleasure. I'm a physical therapist. I was born and raised in Brazil. I specialize in sports physical therapy. I got my master's in physical therapy and then treating very different cases of very challenging patellar tendinopathy athletes. I decided to do a PhD on that topic. It was like 2011. There was not much on that topic at the time. So yeah, it was like either it's an inflammation or it's just eccentric training. So there wasn't much. And during my PhD, I got a scholarship to go and conduct part of my studies at the Australian Institute of Sport. And it was a phenomenal experience. Professor Craig Purdon, he welcomed me there with his group. And everybody who reads tendinopathy knows Craig. He's a co-author of Joe Cook and several classic tendinopathy papers, the continuum paper, the compression paper, all those. He's been doing research for like, I don't know, 30 years or something. He was involved in 5 Olympic Games. He's a legend. I was there for almost a year with him. We did a study on Olympic level volleyball and basketball athletes, looking at their landing mechanics and the trunk position, how much that influences the load in the patellar tendon. We published that in 2017. Then I came back to Brazil. I finished my PhD here, and right after my defense, I got a position as an assistant professor at a university in the northeast coast of Brazil, which is where I live now. I have been an assistant professor here doing research for almost 10 years. I supervise master's degree and PhD students. I teach sports physical therapy, and I supervise the clinical rotations of the students in the last year of their physical therapy school. The group that I lead is Brazilian Tendinopathy and Sports Injury Research Group. We focus mostly on patellar tendinopathy, but some things about Achilles too, and we have some studies that our few students of mine want to look into the shoulder now too. I'm not too convinced I'm going to go deep into that, but let's see. In 2021, I went to the US. I spent 1 year there with Karen Subernagel doing a research collaboration. We did a study in collaboration with Josh Baxter at the University of Pennsylvania in Philadelphia. We did a study looking into the loading tiers of patellar tendon load in different activities, jumping. We did 35 different activities. Yeah, that was a very nice experience too. I came back to Brazil. More recently, I went to Copenhagen too. I did research collaboration there with Peter Magnussen and Michael Kjær. Now they are collaborators in a study that we're doing here in Brazil too. So yeah, I was fortunate to learn from some of the best, and yeah, I'm looking forward to our conversation today.
hmm Okay, let's go back. What were those 3 cases of patellar tendinopathy? Those were, yeah.
Yeah, so I was doing my master's at the time, and there were really challenging cases, and one was a more straightforward one. So one that came first was like a not so challenging case, and I was like, I got this, I know how to treat this. And then the second one came, and it was like there was nothing increase in loading in the previous weeks. Nothing had changed, and the guy had just a very severe case of patellar tendinopathy, a volleyball athlete, very high jumper. And then I looked into the physical exam, and he had like a massive dorsiflexion restriction. This guy had a history of several ankle sprains. He had a very weak gluteal muscle. His landing was very, very stiff. And the other guy that came right after that one was a very typical case of increasing load in the previous week in previous 2 weeks because of a competition. So I look at those and I said, there's no way I'm going to treat these 2 guys the same way. I mean, this guy has a clear overuse because of loading, too much loading. I have to settle that down and then progressively load the tendon. But the other guy, he has kinetic chain important issues that if I don't address those, even if I do a progressive loading for the quads, there's no way he's going to come back and not come back again with the same condition. But I went into the literature and there was nothing into that. It was eccentric training. The heavy slow resistance was just published. It was 2010, 2011. And it was the new trendy thing, but still most people were still just doing the anti-inflammatories. And after that eccentric training, and some people were not even loading the tendon at all. It was just rest. And then I have to dive deep into this. So I just wanted to do a PhD on that topic.
Mm. Yeah, okay. That reminds me of our conversation a while ago about there is that, I think you were talking about that restriction on ankle dorsiflexion leading to more knee, like more knee stress. And just from like using an ounce of logic, I'd be like, that doesn't make any sense because if you have more ankle dorsiflexion, your knee is going to be going more forward, you know? So you'd think more
Yeah.
knee stress. But can you explain why you think this limitation in ankle dorsiflexion leads to more patellar tendon stress?
Yeah, that's beautiful because it's counterintuitive if you think about it. But actually, when you look at the literature, it does make sense because when you have a dorsiflexion restriction, there's a study that saw that dorsiflexion restriction is a risk factor for patellar tendinopathy, less than 36 degrees. And then you look into why that is. You have a systematic review that actually showed that people with less dorsiflexion, they have less knee flexion and less hip flexion when they land, and they have a higher ground reaction force because of that, because they don't dissipate the load in the form of movement, which is what they're supposed to do. Their joints moving, they will eccentrically contract their muscles, they will dissipate the load. But if you don't have those movements, that dissipation of load, the ground reaction force just goes straight up, and it has to be dissipated by either the passive tissues, the tendons, the cartilage, or it's just going to become heat. So it has to go somewhere. The ground reaction force is relentless. I mean, it has to be dissipated by somebody. So if the movement is not happening down there, it's going to cause an overuse condition sooner or later. So that's why we're so interested in looking into that and actually identifying the cause of the restriction too. I mean, it can be restricted because of an ankle sprain and the joint is stiff, so you have to mobilize that, or it can be just stiff because of a muscle shortening, a muscle tight. The soleus is very tight, so you have to stretch that. Some people even have neural conditions like the tibialis nerve, the plantaris, the plantar, medial plantar, and lateral plantar nerve can also be sensitized and cause dorsiflexion restriction. In those cases, you have to treat that with neurodynamics, neuromobilization. So you have to really do an assessment to check what is causing the dorsiflexion restriction if you want to treat that properly.
Mm. Does that reflect how, so we have this, I think idea of the soleus and the quad kind of working together. And the soleus can maybe like do the, like quote unquote, do the job of the quad or whatever someone wants to call it. When you have that ankle dorsiflexion restriction, does that affect how the calf muscles are working?
Yeah, that's the premise that we have too. We're checking that now. We're seeing if that really reflects what we see in a biomechanical assessment, but that's what the literature actually shows us. Like, if you don't have dorsiflexion movement, you don't have the calf muscles don't engage as much to dissipate the load. So they don't have movement in order to actually dissipate that load and in an eccentric contraction, actually lengthening the muscle. So the load has to go up, and the quads will have to do all the work, especially if the hips are not doing much, and if the person is landing very stiff with the trunk very much upright. So the quads is doing all the work. That's what we saw actually. We looked into the patients when we look at them landing. I was expecting to see quadriceps avoidance landing with pain because, well, if they use the quads, they're going to feel pain. So they're going to avoid that. They're going to do trunk flexion. They're going to use their ankles more. Nope. They still keep using, it's like they're trapped in a movement pattern and using the quads because that's how they learned to dissipate the load, and that's all they do. They always land trunk upright, only the quads doing the work. The ankle doesn't allow movement. So that's what we think happens now. That's why we are trying to dive deeper into what happens in a biomechanical setting when we land with more or less dorsiflexion, with more or less trunk flexion. How does that affect the patellar tendon load?
Hmm. So this landing study, that was landing on one, or was it landing bilateral?
So the one that we did in Australia was with Olympic volleyball and basketball athletes. We asked them to land from a bench, and they were landing bilaterally with their trunk in a self-selected position first, and then we randomly changed that into very upright trunk position, as upright as possible. And the other one was project your hips back and move your trunk forward a little bit.
Mm.
And then in a bilateral landing, we saw that it makes a lot of a difference. The trunk flexion decreases the patellar tendon load by one body weight. So it's on average 7 times your body weight when you land in your self-selected position with both legs. If you have your trunk upright, it goes up to 7.5, maybe 8 times body weight. And if you do a trunk flexion, it goes down to 6.5 times your body weight. So just a little bit, and it's like 10 degrees, 15 degrees of trunk flexion with projecting your hips back is enough to decrease on like one time your body weight on your knees on a bilateral landing. And what we saw was that some people would land asymmetrically. They would land first with one leg and then with the other. And with these guys, with the trunk upright, landing first on one leg and then the other, the landing force was over 14 times their body weight on their quads with the trunk upright. So, I mean, there's no way that that's not relevant. And if you look at how much it can double the load in the tendon just by the way that you decide to do the motor pattern. So we have to be mindful of that when we are rehabbing these guys.
Mm. So this, you're kind of looking at this hip flexion can kind of offload the quads. So if you looked at maybe in training, that's something in patellar tendon rehab, because I think maybe early on, especially when I got into it, you see all this quad literature, and it's like I need to work the quads, do leg extensions, but it's like then is your whole program just quads, you know? And then you do nothing for calves, nothing for hips. So yeah, for you, for that idea of that hip flexion, because I would just guess any athlete in a jumping landing sport, if they could have the ability to use hips more, they're going to offload the patellar tendon quite a bit more. So is that a big focus in for you in patellar tendon rehab, is doing something for, what is it for, hamstrings, glutes, or what exactly?
Yeah, that's a great question. So we do the 4-stage rehab here, similar to what you have in your program. But what we do is in phase one, in addition to the isometrics that we do for the quads, because we want to reduce the inhibition, we want to load the tendon. We want the analgesic effect that some people have with the isometrics, heavy load isometrics sustained if possible. We also do a lot of work for the glutes, glute max, a lot of work for the soleus. We work on the dorsiflexion restriction. I teach them variability of movement in landing. So I want to teach them how to land in a different way that they're used to doing. Because it's not about this movement pattern is right, this one is wrong. It's about having variability. Otherwise, you just land the same way, you load the same tissues the same way all the time. So that's a big part of what we do in stage one, especially in the days that they have a lot of pain. They have too much pain in the knee. Even the isometric is very painful. Sometimes we use electrical stimulation in the quads. We saw that actually helps load the tendon a little bit more, and it also decreases the pain. But in the same time, I'm focusing a lot on the glutes, a lot on the calves. So I want to already have strategies that will offload will decrease the excessive load that the patellar tendon is getting, especially if they're still training. So a lot of people are not willing to stop training for like 12 weeks, which is what most protocols typically take. So if you are going to keep training, I need you to train efficiently. I need you to train with variability of movement. I need you to dissipate the load in the different joints of the lower limb, not just on your quads. Otherwise, you're going to keep having this overused every time.
Mm-hmm. When it comes to the calves, I guess a lot of that talk is on the soleus helping to offload the patellar tendon. What does your training look like for that?
Yeah, we do a lot of calf raises. I love doing seated calf raises in the beginning. I do a lot of those in the beginning with high loads. I want to really, I test the loads bilaterally. I test their repetition maximum, and it's surprising to see how often they have weakness there. I mean, the quads, the soleus is very strong, like 1.4 times your body weight. And the problem that some people just want to do calf raises body weight, and they think that's enough, and that's not enough for the soleus. You need to really load the guy. You need to have unilateral attention for the soleus. We do bilateral of everything for the quads as well. We do a lot of focus on the contralateral quads because of the whole literature showing bilateral alterations in people with unilateral pain. So I don't want to rupture in my clinic, so we do heavy training for both legs in the beginning already, sometimes unilateral. I do standing calf raises in the Smith machine. That's one of the things that we do a lot. We do a lot of seated calf raises in the beginning. So mostly exercises that will just be calf raises, heel raises with the vector up. in the beginning, but then I really, in the intermediate and second stage, when I started to do heavy slow resistance, and especially before I start doing the plyometrics with them, I really want to work on the soleus with their diagonal vector, because in closed kinetic chain, the soleus doesn't just do plantar flexion, it also extends the knee. There was a study that showed that the activation of the soleus is much higher when you do plantar flexion with knee extension. So we do a lot of plantar flexion with knee extension in that diagonal format. So they actually do a lot of emphasis on the soleus in the closed kinetic chain action that it does. So that's mostly what we do for the lower aspect of the kinetic chain, in addition to improving the dorsiflexion range of motion. So a lot of mobilizations, stretching for the soleus, if that's the case, strengthening in the whole range of motion, because if you do strengthening in high range of motion, you also improve your mobility of the joint. So those are the main aspects that we focus on.
Mm. Okay, so doing plantar flexion, focusing on plantar flexion is going to help the dorsiflexion range. That's what you've seen.
Yeah, there's a study that showed that too. So they compared two groups. One group did only stretching, passive stretching, and the other group did eccentric training with high range of motion, in the complete range of motion. And both groups got better with the range of motion, with no difference between groups, which doesn't really surprise us, because if you train heavy in high range of motion, of course your joint is going to gradually improve their range of motion. And in my view, that's even better, because you get the benefit of strength training in addition to the benefit of improving range of motion, instead of just doing passive stretches.
Mm. Okay. The E-stim, you said this earlier, E-stim on the quads. Is that something from Delaware? I've
Yeah.
heard the
Well,
car and doing
I
that.
am. I am
Yeah, yeah.
their child. So yeah, I am
Okay. Yeah, tell me a
glad.
little bit about that, because I think I look at it with the patellar tendon, and it's like we want to get good activation of the quads to get strain on the tendon.
Yeah.
But I think, yeah, one of her piece of research putting E-stim on, seeing
Yeah.
quite a bit more strain in the tendon. Yeah, tell me about that.
Yeah, so we have a lot of people who have a very strong fasciculation when they're contracting their quads. I'm sure you see that too all the time. You ask them to do an isometric, heavy isometric, and their quads is all over the place, shaking. And we don't want that plyometric stimulus in the tendon in the initial stages. So we either do the Berlin method contractions with a shorter duration when we see that, or we do electrical stim, which is my go-to nowadays, to try to get that longer duration contraction in the quads, in addition to the electrical stimulation. So I like the medium frequency currents, but you also have the shorter, the low frequency current too. That works very well. You do big electrodes in the motor point of the rectus femoris, one in the vastus medialis, heavy contraction, as heavy as possible, as high intensity as they can tolerate, and they do the isometric contraction in addition to that. So you can either do a closed kinetic chain exercise like the Basas Spanish squat at the same time as you do that, or you can do what is typically my go-to for the first stage, an open kinetic chain, knee extension machine, unilateral. You do that at the same time you are stimulating the quads to get that really nice contraction, reducing the inhibition and getting the long duration contraction without that fasciculation that I really don't want in the initial stage.
Hmm. And you're doing this on people with pain.
Oh,
Are there
absolutely.
some where, yeah, are there some where it becomes too much? Is it, or have you not seen that?
No, it's interesting. There's a study by an Italian group that the first author is La Banca. They actually saw that they compared the heavy slow resistance with doing sitting to standing with electrical stim at the same time. And they saw that both groups got better, but the group that did the electrical stim at the same time progressed with less pain than the group that did the heavy slow resistance in isolation. So when they're getting that really heavy stim for the quads, they kind of forget about their knee pain. They kind of
Mm.
shift their focus, their attention away from their knee pain. So it's very interesting to see how some people that cannot tolerate even isometric loads, they tolerate that a lot better with the electrical stim for the quads. It's a very strong stimulus. They focus on what's going on in the quads, and they just forget about their knee pain. What I have to be careful about is sometimes we get a little bit too carried away, and then their pain in the next day gets worse. So I asked them to do the testing, the loading test the next day, and their pain was very manageable, and then it becomes very high. So you have to be careful of that. But other than that, It's a very, very powerful tool for us to use in the initial stage.
Hmm. Okay, going back to that, the Bossa Spanish squat study, I
Right.
remember they had, I don't know, were you a part of that? There was like 4 subjects and they saw like pretty significant strains. What did you make of that in terms of, I think some of them were like double-digit patellar tendon strains?
Yeah, so that strain, people have to be mindful that that strain is not the same as when you read the strain in the actual fascicles and the actual tendons. It's different. So yeah, there was a very high strain in the patellar tendon using that method. They used the tensiometer in the tendon. I was there in the beginning of the pilot studies, and it was a very tragic thing too because it was Carlos Bassaz. I don't know if you know the story, but they died. They tragically died in a car accident in New Zealand.
Mm.
Uh,
Yeah, I heard that.
Angel, Angel Bassas, yeah, the guy that came up with that, the Spanish squad, and his son Carlos was in Delaware doing data collection there, and he was like a young kid. He was 17. He wanted to study physical therapy, but he was traveling the world to first learn from the experts, and he was there with Karen for a while. And while they were there, they did this pilot study looking into the loads of the Bassas squat with and without ischem, measuring the load with the tensiometer, and they found that when you do that with the e-stem, there's a lot of variability. The 4 subjects were it was all over the place, but you can clearly see that the load increases substantially with the e-stem, which kind of makes sense too because you have inhibition. The muscle is not really pulling as hard as it could. So you just give a very powerful electrical stimulation to the muscle to help it load more. And since we know the tendon is mechanosensitive, it needs the load, it needs the strain, as Jared McMahon says on his editorial, no strain, no gain. So you need to strain the tendon to get the actual stimulus. So if we have more strain there, that's what we want in the beginning. But yeah, then they both died before they wrote that paper,
Mm.
tragically. So Karen actually finished the paper, and in the acknowledgments, she actually thanks Carlos and Angel for their contribution. That's why she's calling now the Bassaz squad as paying tribute to their contribution to sports medicine.
Mm. Yeah, okay, that study, yeah, that was those numbers were pretty significant. This reminds me of I'm curious on your thoughts here with so yeah, the no strain, no gain. You know, we got to strain a tendon to get adaptation out of the tendon. You have the Berlin method with like I think they're 3 seconds or are they 5? Maybe they're 3 second holds.
3, yeah.
Yeah, 3 second holds with the Berlin group. And then we have like the Ebony Rio 45 second holds. How do you look at these distinctions of like both of these are going for to I don't know, train tendons, adapt tendons. Yeah, what do you make of this discrepancy in time frames?
Well, they both work. So the Berlin method has very little research with pathological tendons. That's the only problem. That's the only issue I have, because they only have one very small study looking into people with pain. The rest, everything that Adam Potts' group did was with healthy tendons, and they did see that if you don't have enough strain, if it's not 90% of the MVC, you don't really get the strain that gets into that 4.5 and 6.5 range that they talk a lot about actually being necessary to get that mechanical stimulus. But their studies are only with healthy people. There's only one study with people with pain, and they did show that people got better with the uh, short duration isometric. So my go-to option is typically the long duration isometric because I really want that time under tension. I want that analgesic effect that we see so often with people after a long duration isometric. But some people can't tolerate that. And that's the problem. And you see the study that Ebony did was only 6 people. So they had a small sample. When you actually apply that into the real world, you see that a lot of people don't respond as well with long duration. They have a lot of pain. They have a lot of fasciculation in their muscle. So for those guys, I love using the Berlin method because it's short duration, higher intensity, 3 seconds on, 3 seconds off. I typically try to get that done in the beginning of the session so I can make sure that when they still have a lot of energy, they got the tendon loading properly. And then I focus on the glutes, I focus on the calves, I focus on improving dorsiflexion range of motion. And then we have a whole session just with those aspects of the rehab. But if I
Mm.
can, I would prefer the longer duration exercise because of those things I just mentioned.
Okay, and you're thinking the people.
What
Yeah,
do
go
you
ahead.
think about that? I'm just really curious to think
Yeah,
about what are
well,
you doing.
yes, because I've kind of always thought that like when you have these people that get the increase in pain symptoms, maybe during, but especially like after and the day after, I've always kind of wondered, is it that you're just straining, giving the tendon too much strain? That's kind of what I've wondered, you know? Is it just reaching like I guess the if you would just say like the absolute strain maybe is too much for what they're tolerant. So, and I've kind of, if they're doing a 30-second isometric with 30 with 100 pounds, you know, I'm like maybe that 100 pounds is too much, and maybe we need to decrease that 100 pounds. But then if we do 30 seconds, it's not really stimulating on the muscle because you're not really getting fatigued, you know. So I kind of went longer, but I haven't thought of it the way you're thinking of it. That those long duration isometrics could be, you think they're causing issues because, well, when these people get the fasciculations, you're thinking it's causing like this almost elastic response in the tendon,
Yeah.
and that's why things are not, it's not feeling good.
Yep. That's exactly the way I feel about it. And that's what I see too. I mean, after we do that long duration, like forcefully, the patient can't really hold that, but they're like trying for dear life to continue the contraction. And the next day, they're very often worse. So I'm assuming it's because we gave the fast contraction stimulus that we already saw in the literature that don't really get tendon adaptations. The whole plyometric versus slow duration, slow velocity, high intensity contractions. We know that the tendon needs this low velocity to actually adapt more structurally. So yeah, that's my thought.
Have they, so has anyone looked at when you're doing a hold like that and you're getting those crazy fasciculations, has anyone looked at what's going on in the tendon? I know Seth O'Neill had a video about calling like tendon tremors, he would call them. When you're going down on the eccentric, you just like quiver a bunch, and he was thinking that you're getting this violent, I don't know, stretching of the tendon. But has anyone seen that when that's happening, or has that's not been looked at?
I don't think so. I don't think anybody's done that. Yeah, it's a good thing to look at. I mean, the Berlin group has a lot of studies looking into the tendon dynamically now too. They have the ultrasound trapped to the like to the patellar tendon when they're squatting, and they're doing some really fancy, crazy shit, which is very interesting. I'm very much looking forward to see that. But yeah, that's something that we can try to do here too. We have an ultrasound. We can try to take a look at what is actually happening in terms of strain. The problem is with the patellar tendon is it's too long, so we can't get the whole image of the patellar tendon in one view of the probe. We need the guys in Copenhagen. They have a big probe. They can get the whole patellar tendon in one image. We can't. So maybe something for us to do with them in collaboration. Maybe put the big probe there, check how much it has in length in like when they're relaxed, do a contraction with tremor and see how much it changes, how much the strain is different in relation to an isometric contraction in different intensities, something to look to actually explore more in research.
Yeah. Oh yeah, that could be big if that's what's leading to these increase in pain symptoms, and maybe it's not the load. You know, maybe it's not the absolute load they're using because it is it's you're trying to do an isometric and it's not really isometric at the tendon if you're getting this.
Not at
Yeah.
all.
Yeah. Um okay, so before I go on to I was gonna, yeah, before I go on to like more specifics with quad patellar, that e-stim for the quads, has it been done to get more strain out of the patellar tendon? Has that been done with the calves and Achilles tendon?
Yeah, there's a group in Brazil now doing that. It's a very strong group that we have in the Midwest of Brazil. It's a good friend of mine. He actually spent a year with Karen too. After I went there, he went there too. His name is João Dorigan. He's the first author in the systematic review that they just published on JOSPT about the e-stim for tendons in general.
Hmm.
So they're looking into what happens with the calf now too. So they're doing a study looking into the strain and the elastography of the tendon with and without e-stim. They're doing some studies looking into the muscle as well, not just the tendon, but the muscle too. So they're very heavily stimulating the muscle, and they have an ultrasound in the muscle too to see what happens in terms of pulling, how much it changes the pination angle, and yeah, I'm very much looking forward to what's coming out of that. That they have two PhD students looking into that right now. Looking forward, maybe next semester, maybe next year, we'll have something on those results. In clinical practice, I actually do that too. We don't really know what happens yet, but especially in patients that have a lot of difficulty getting that heel raise, we like to do isometric contractions with E-stim too in the beginning. So it's a way of loading the tendon in a stage where they don't really tolerate all that much. So it's something that pragmatically we use a lot, but not really. There's not much research on the topic yet.
Yeah. Okay. Going the opposite way of E-stim, BFR. What are your thoughts BFR for
Yeah,
tendons?
that's a very trendy topic now too. It's cool because I was in Copenhagen now, and now they're doing a study there, and it was interesting to see some of the preliminary results that they have. There's one good study showing good effects for the elbow tendon. So they published that on JOSPT. The Karanasius is the first author. They did BFR here approximately on the shoulder, on the arm, and then they did exercises for the extensor tendons, supination, and they found good results in reduction of pain and improving of symptoms in general in the group that did BFR versus the group that did sham BFR, which was just placing the cuff and not really doing anything with the cuff. It was just exercising. Uh, for the upper limb, for positional tendons, I think it makes sense because they don't really need that much load. They need a shorter, a lower intensity of load. They all already get better with that. But for the lower limb, I'm very skeptical still because of all the research that we have showing that you need high load to get an adaptation. And the whole premise of BFR is to get a stimulus for the muscle to get stronger, to get hypertrophy, even with low loads. And then we would have what Folk Mersman talks about, the imbalance between the muscle and the tendon, because the muscle will get stronger, but the tendon won't follow. The tendon will not get the stiffness that it needs in order to tolerate the higher load that the muscle is producing now. So yeah, I'm not a fan for lower limb. I have been playing with for the elbow because I saw that paper showing good results. But for the lower limb, I'm still very skeptical. I'm still waiting for more research to come before I start using that.
Mm. Okay.
What do you think
Yeah.
about that?
Yeah.
It's
I'd
good to
also,
hear.
I mean, that makes a lot of sense that well, your thing with the vesiculations, I'm going to need to think about that as far as like the long duration, because it does make me kind of rethink things. And I'm going to have to think of cases that I've seen where that's happening, and maybe it is causing pain, and experiment with like shorter ones. But yeah, exactly, the BFR thing, I've kind of used this distinction with like the muscle can get a mechanical tension adaptation and a metabolic stress adaptation, but the tendon needs the tension or the strain. It doesn't adapt to the metabolic stress, at least right now. So
Yeah.
yeah, I guess it would lead to that imbalance, like the Berlin group says. But I've gone that BFR. I've kind of thought early on it could be good when someone can't tolerate a lot of load. But I was going to ask on this because my friend Trent Salo. Have you ever met Trent?
No,
He's
I haven't.
okay. He was with in the NBA, and now he has a tendon clinic in
Oh,
Traverse City, Michigan, where he has a
cool.
UTC scanner and he does a
Oh,
battery of patellar Achilles tendon stuff. But anyways, he was with Karin maybe a few months ago,
mm,
and I had asked him about the strain thing that you kind of talk about, like putting the E-stim on and getting a lot of strain on a tendon. And I was like, isn't there like a concern that you're going to overstrain, like strain the tendon too much? And he was like, I think he said he might have asked her that, or maybe he asked someone else, and they were just like, no, there's no fear of like overstraining with the isometrics, because that would be my justification for the BFRs. I'm like, if you have a really sensitive tendon, the BFR is not going to offer really any tendon strain because the muscle is not really pulling hard at all. There's really no force going through it. So it seems very safe. But where do you stand on this whole thing of like, can we overstrain the tendons in rehab, or in an isometric setting, or in like a slow strength exercise? Or do you think that's not a thing?
I mean, you could in a very heavy eccentric contraction, but not in isometric. No, you don't. You don't get enough strain in an isometric contraction that could be damaging, could be in any way prejudicial to the tendon. There's no way you can do that. No, I mean, eccentric contractions, on the other hand, can be problematic if you do a very long range, heavy load, but not for isometric. No, I haven't seen anything on that.
Mm. Yeah, and it probably as well, like there's not any um ruptures. I mean, I haven't heard any cases of ruptures with that. I guess one case does come to mind where a guy was doing a quad test, leg extension, overcoming test with a quad tendon repair, and he re-ruptured his quad tendon. But I think that's a case where like you went from 0 to 100 in the test. But as long as you gradually build up, because then that's like an elastic violent thing. If you're going, that's like a plyometric. Um, yeah.
Yeah, for ruptures is a completely different thing. I mean, you have to be careful of that, especially like you said, like the high intensity in a short duration time can be problematic, yes.
Mhm.
Especially because you don't want the tendon to heal too long. I mean, that's the biggest mistake I see people doing after like an Achilles rupture. I see a lot of people really forcing dorsiflexion, trying to gain range of motion as if that was a problem. Like nobody ever got a restriction in dorsiflexion range of motion after rupture. It's the opposite. They heal too long, and then you lose performance because of that. But because people don't really study that in depth enough, they treat it like an ankle sprain. They want to improve dorsiflexion. They're concerned about range of motion, and then the tendon just heals too long, and you just lost your surgery.
Yep. Okay, patellar tendon versus quad tendon. I think I was telling you that you go on for me, there's that one study, and it was what I got from it was the knee flexion. As the knee bends more, it's going to be straining the quad tendon more versus the patellar tendon's more shallow. Um, if that's completely accurate, correct me. But yeah, what have you been looking into in terms of patellar and quad tendinopathy or patellar and quad differences?
Yes, that's good. We're doing some studies on that too now. We're looking into some data that we collected with the group in the US, the Josh Baxter. We did a few pilot studies looking into ultrasound to look where the quadriceps tendon gets more compression against the trochlea when you're flexing your knee. Because I firmly believe, from what I've heard and what I read, that quadriceps tendinopathy has more to do with compression than it does with tension. So it's more of a compressive issue, similar to an insertional Achilles tendinopathy. So we have to be mindful of decreasing compression in the initial stages. So in the opposite direction of actually doing deep knee flexion because you want to load the quadriceps tendon more, what we typically do in the initial stage is we try to load the tendon by bending your trunk back, leaning back, because that way I get more load uh, in the rectus femoris, which loads more the quads tendon. But I don't want to do that in the compression range of motion in the beginning because the tendon doesn't like compression. So that's the difference between what I see people doing all the time and what I've been doing. And I've been quite successful with that approach lately. So, of course, we need to do studies on that. We need to actually measure those things. And there's really little research on the quad tendinopathy in comparison to the patellar tendinopathy. We did a study looking into the quadriceps tendon loads, like the study that I told you about, the one that we looked into the loading tiers for the patellar tendon. We also measured the quadriceps tendon load. And I think you published something about that. You posted something about that on your page. We looked into the graphs. The loading tiers are almost identical for the quads and the patellar tendinopathy and the patellar tendon. So there's not much difference there. I mean, for one study, the Bulgarian squat, for the one tendon, the Bulgarian squat is before and the sumo squat is later, and the other one just reverses, but they're all in the same area, like low, moderate, and high. There's no difference there. For the quadriceps tendon, the trunk leaning back, we didn't really test that in the beginning. Those 35 exercises, we didn't do anything looking into that. What I do like to do for the quads tendon is introduce that really early on. So I do uh, isometric contraction with the trunk leaning back in the knee extension machine. I like the reverse Nordic exercise for the quads tendon, which I don't use for patellar tendinopathy because I don't want to compress the patellar tendon against the floor. But for the quads tendinopathy makes sense because I want to load it more leaning back. So in the advanced stage, that's something that I use. But we don't have much on that. I mean, the few studies that we have, there's one from Andrew Sprague and Karin talking about, is it semantics or is it the same thing, quadriceps and patellar tendinopathy? The deep knee flexion does make sense in terms of loading it more, but in the initial stage, we need to be mindful of the compression. That's the only thing I would really highlight here that I haven't heard people talking about enough.
Mm-hmm. So it's I look at I think early on I looked at compression as like the tendon pressing against a bone, but then more recently has been like the tendon wrapping around a bone. Like when you get into deep, like the calcaneus, you get into deep dorsiflexion, it has to wrap around more and has like this compressive effect, just because of the wrapping. But with the quad tendon, the compression is, it's not from wrapping around the patella, it's from actually pressing against the trochlea.
Yep, exactly. Yeah, we have a video of that. I think I sent that to you too. We have a video where we're looking into the quads tendon when we're doing flexion and extension of the knee, and you can clearly see it being compressed against the trochlea. When you're above 60 degrees, 70 degrees, that's when it starts typically. We have to do studies on more people to actually see if there's variability in that angle specifically where the compression starts, because I'm assuming it will change a lot if somebody has a patella alta. It will change how long the patellar tendon is, how long the quads tendon is. But that's definitely something that I don't want in the initial stage. We don't really know which angle exactly that starts to happen. But yeah, I try to stay away from something deeper than 70 degrees in the initial stage. And I just lean the trunk back to actually load the quads tendon more. And then as the rehab progresses, of course, I want to prepare them gradually to tolerate that. So we see a lot of quads tendinopathy in weightlifters that have to like do squats below parallel. And of course, we have to prepare them for that. And that has to be introduced in the advanced stage of rehab. But I don't think it makes any sense for you to keep loading them in deep knee flexion in the initial stage when they already have an overuse with a lot of compression in their tendon.
Yeah. I've kind of looked at it as like the insertional tendinopathy for the Achilles. You look at it the same way of like, let's try to
Same
avoid the
thing.
deep. Yeah.
And what pisses me off is that a lot of people don't have any idea of how compressive loads can be bad for tendons. So everybody that came to me with a quads tendinopathy was stretching their quads like crazy because everybody told them they had tightness in their quads, they had to stretch. And then just by removing the excessive compressive load, same thing with the Achilles. Just by doing that, you already decrease their symptoms. You just do exercises away from compression in the beginning, heavy isometrics if you can, E-stim, same thing. I would really like doing that. You already have a decrease in symptoms in the initial stage, and then gradually you progress the loading, and then gradually you progress the deep knee flexion angles too. But in the initial stage, you have to stop poking the tendon, stop compressing it against the bone.
Hmm. So that by leaning back, leg extension, and then I guess you get the same with that reverse Nordic. Getting more of the rectus femoris is getting better strain through the quad tendon.
Yeah, it's the biggest tendon. It's the one that is typically also used for ACL reconstruction too. They take that away because it's a very good, very strong tendon. It's long. They're individual. The vastus medialis, lateralis, intermedius, and the rectus femoris, they are very separate tendons. And what we see is that the rectus femoris tendon is often the one that is more problematic. So you need to actually load that specific guy a lot more. And we have the fact that it is a biarticular muscle, we have the opportunity to load it more by moving the trunk position, which is something I don't see people doing as well. They don't understand the pathophysiology enough to actually understand that you need to actually load that guy specifically, the rectus femoris tendon. But I guess that's how we approach it now. But I'm really looking forward to seeing more research coming on that topic. If nobody does it, we're going to have to do it something here because, I mean, we have to stop just looking at the big guys, the patellar, the Achilles. I mean, T-post, tibialis posterior, you have almost nothing. Peroneus muscles, almost nothing. And I see a lot of that with runners here. So we need to start looking into that literature more, diving into that. And if nobody's doing, somebody has to do it. So we'll have to start doing something too.
Hmm. Yeah. Okay. So you're looking at that leg extension leading back, and then the reverse Nordic, getting that rec fem better for the quad, or better for, yeah, getting that quad tendon. So then all the other options, I'm thinking like leaning forward, leg extension, leg press, squatting, like all these things are not going to be as good for that quad tendon.
Nope. I mean, it does make sense if you want to focus on the glutes too. I mean, it depends. There's no right and wrong answer here because if you want to do a squat with emphasis on the glute, you should be leaning forward. And of course, the glute being stronger, it will decrease the load, the excessive load in the quads tendon too. So I don't think it's wrong to do that, but it depends on your focus. Do you want to strain the quads tendon more? You have to lean back instead of leaning forward. So, I mean, you can play around with those variables. Same with the quads tendinopathy. I would also address the kinetic chain. Same soleus. I look into the glutes. Very often they're weak. A study that we did in my PhD, we found 27% less strength in the gluteus maximus in people with patellar tendinopathy versus controls. So it's almost 30% less. So if you have three muscles generating force for your propulsion, you have the calf muscles, the quads, and the glutes. If one guy is working 30% less, somebody's going to have to pay the bill. Otherwise, you're going to lose performance. Either you lose your jump vertical heights, or the quads or the calves are going to have to work more. So, I mean, there's no way you can ignore a 30% weakness in the muscle and not expect something to go wrong. So that's why we give a lot of emphasis of that about that in the beginning, in the initial stages. And then we can play around with the trunk position to do that, like we talked about.
Yeah. Yeah. That quad, that rectus femoris, I was looking into a few pieces of research with the patellar tendon, and you have like the posterior fascicles that just come like the ligament section, but then you have the tendon section that runs all the way from the top. And the couple pieces I was reading was the rec fem turns into that rec fem tendon. It's like it's superficial, so then it turns into the most of the patellar tendon. So I'm looking, everything you just said, quad tendon, I would think would pertain just as well for the patellar tendon. Do you think there's anything specific about those posterior fascicles of the patellar tendon? Like, is there any exercise, any position that you would speculate could load those better, or they're probably just going to be loaded anytime you load the knees?
Yeah, that's a good question too, because we did a study in Delaware looking into the amount of strain that the different parts of the patellar tendon have during isometric contractions. We published that 2 years ago, I think. So we looked into strain of the medial part of the patellar tendon, the central part of the patellar tendon, and the lateral part using an ultrasound during contractions in different intensities. And we saw that it doesn't behave the same. The strain, the differences in strain that we see kind of challenge the whole premise that the patellar tendon is uniform and it is loaded the same with different exercises. And then what we have been trying to do is, because specifically of what you said, the quads tendon kind of continues into the patellar tendon, and the most frequently pathological part of the tendon is the posterior part, especially in the medial side. We try to emphasize exercises that will also load the quadriceps tendon more, especially in advanced stages of rehab. I cannot forget to also load that part. So it's kind of similar, but kind of different, because in the patellar tendinopathy, I will also include that stimulus in an advanced stage, whereas for the quad tendinopathy, I will include that stimulus very early on because I want to load that proximal tendon more. But it's very important, like you said, the tendon is a continuity. It's the quad tendon that becomes the patellar tendon. So something to keep in mind.
Mm-hmm. So in the Achilles, you have those three subtendons that have that twist, and there was some like bodybuilding stuff where it's like you could turn the foot in and get more, I think, lateral gastroc, turn the foot out more medial, which would then maybe be straining those subtendons more. Do you know of any way with the patellar tendon of changing where the strain? You said medial is where you get some of that pathology more. So
Yeah.
is there a way to turn the foot or to change the hip, anything like that, to load the patellar tendon differently?
Well, that's something for us to research. We haven't seen that yet because the study, like we just published that, is very new. But what I do in practice is I do e-stim. Like I said, I put the electrodes, one in the rectus femoris and one in the vastus medialis, because I want to strain that part more. Because we see there's plenty of literature showing that the medial side of the tendon is typically more affected than the lateral side. So I want to make sure I get that load there. But people tried a while ago to see if internal rotation or external rotation of the tibia would make a difference in the patellofemoral joint load, and they haven't seen much difference there. It seems like it's quad contraction that actually matters. But with e-stim, I think it does make sense. We haven't actually checked how much the strain differs in e-stim versus non-e-stim, but it does make sense. If you have a more pull because of the strain of the e-stim, and you put the electrode exactly in the medial side, it does make sense from a mechanistic point of view that the medial side will be loaded more.
Mm-hmm. Have you seen? Okay, so I get people come to me with we talked about quad tendon, patellar tendon, the distal patellar tendon, the Osgood Schlatter area. I've had people come to me for that, and I just actually I had a guy yesterday, and I'm like, just do regular jumpers knee rehab. There's no differences at all. Where do you stand with that? Is there anything out there that suggests there's could be a difference?
Well, I do like. Have you seen Michael Rathleff's research
Yes.
on that?
Yeah.
Yeah, he's a very good guy. I do like his progressive physical activity for those guys. I mean, what I do a lot for young people with Osgood Schlatters is I want to offload that specific part of the tibia that is being excessively loaded in the beginning. So again, kinetic chain plays a big factor on that. I do a lot of emphasis on the glutes and in the calves in the beginning because I don't want that. I don't want them stretching at all. Every single one of them comes to us with a stretching regime that somebody prescribes stretching for them. I mean, often you have no muscle tightness. There's no restriction in range of motion. Why the hell are people prescribing stretches? I have no idea. It's beyond me. And there's not enough strain from the stretch. I mean, it's just laziness. It seems like something that people just do out of a protocol. But anyway, and then physical activity progression using Reflef's exercise program. I mean, I think that's brilliant. That's very interesting. It's very challenging because they're typically young guys, especially the ones that are very pressured by their parents about their physical capacities. They're sports specializing very early. So we talk a lot with the parents. We talk about load management. We talk about variability of stimulus in the beginning for children, for adolescents. They need to practice different sports so that they stress different areas of their bodies and not the same joints the same way. If we want to have them more successful in a career with long term. We did a study on muscle injuries for Brazilian football players. You call soccer in the US, but
Yeah.
we did a study looking into the prevalence of muscle strains, hamstring strains specifically. And we saw that the early athletes, the young athletes, have a similar prevalence of hamstring strains than professional athletes. Like under 11, under 12 years old, they're already getting the same prevalence as professional athletes. And if you think about previous injury being the biggest risk factor for a future injury, I mean, unless we start doing prevention for the children, we start giving them variability of stimulus, load management, strengthening muscle exercises for them instead of just saying play as much as you can, as hard as you can, it's going to go wrong. And especially in the US, when you have so much pressure for young kids to become the successful athletes of the city, of the specific sport, it's very important to give them that variability. So I guess that's how I approach it. But I would very much like to hear what you think about, instead of just trying to give them progressive loading for the tendon, do you think it makes sense for us to actually think about distributing the load between the joints too?
Oh yeah, for the Osgood.
Yeah.
Osgood Schlatter. Yeah, yeah, yeah. Um, Yeah, that's what well, I was asking it more on the mature, but exactly the Osgood Schlatter. I'd looked at Michael Rathleaf stuff a while ago because I was trying to figure out the apophysitis issues,
Yeah.
and yeah, so I will tell people to do like much more gentle strength training, and then like try not to come out of sport completely because then you get the peaks and valleys with the loading, but like try to get on the same page with your parents and the coaches and the medical staff if you
Yeah.
can, so that they can listen to your pain. And yeah, if you're just playing one sport, that's probably not good. You know, you should probably do something else. So, but I also look at lifting. If they're not lifting, and
Yeah.
I have them lifting, it could also be that's also kind of like playing another sport because you're getting
Oh,
variation of movement. You know, somewhat, not a whole lot, but it's like it is a very variation of stimulus. Um,
Do you
yeah,
get
but
a
no,
lot of do you get a lot of Sever's disease in your calls or your clinical
no,
practice?
I don't know if I've ever actually had one of those. More so kids with knees. I think people know me for
Oh,
knees. So the
yeah.
kids with
Mhm.
Osgood and even like patellofemoral stuff younger kids or patellar tendon, younger kids will come to me with calls with their parents. But I don't think I've ever had a case of severs. I've
Mhm.
listened to podcasts about it and heard some cases of it, but have you seen it?
Yeah, we have a few cases, and it was interesting because when I was in Delaware, Karin was doing a study on that with her students, Sean Hanlon, the guy that did this subgroups study.
Uh-huh.
He did a study on Sever's disease too, and it was interesting to see that a lot of those children actually have insertional tendinopathy. It's not apophysitis. If you they've never when you look at the literature, nobody had actually looked at their tendons before. They were always assuming that it was a growing pain, it was an apophysitis, but they actually look at the tendons. They looked at how thick it is, if there's any tendinopathy in the insertion, and they actually found a lot of tendinopathy insertional in children, like developing children. And they're now trying to come up with a loading program that makes sense, keeping compression away too for that specific population. But it's kind of challenging. I mean, treating children is completely different than treating adults. I mean, you can't just tell them do heel rises and expect them to do them. So yeah, it's
Yeah,
a challenge.
exactly. If I do phone consult with a kid and parents, it's always a little bit awkward because it's like you're working through so many other people instead of just working through one person. And then it's a
Yeah.
kid. You don't know. You can say avoid dorsiflexion, and they're like, "What is dorsiflexion?"
What the hell are you talking about?
Yeah.
Yeah.
Okay, when you guys did the loading index study, you had
Yeah.
the the patellar. I didn't know you guys did quad tendon. I remember
Yeah,
patellar
we
tendon.
did,
Okay.
we did quad tendon, we did patellofemoral joint, and we did a patellar tendon. We compared the three, and it was very similar. So, like I said, the patellar and the quads is almost identical. You will see one exercise up, one down, but the tiers pretty much identical. So you don't really change all that much.
Uh-huh.
But like I said, we didn't do any exercise thinking about specifically focusing on the quad tendon. We were just looking into the literature for patellar tendinopathy. My main goal was to look at the patellar tendon. So I looked into every protocol that exists for patellar tendinopathy, and we came up with the 35 exercises. I wanted to do 42 exercises actually, but Karen talked me out of it by making me do all of those. She said, "You're going to do all of those, and then we will come up with the exercises." And say, "Yeah, you were right. As usual, you were right. So let's kick these two out." And then we came up with 35. But we wanted to see the patellar tendon literature. That's what we were focusing on. But like, since we're here already, let's calculate the load in the patellofemoral joint and in the quad tendon as well, so we can compare, so we can see if these exercises make sense for them too. I looked at the ACL literature too, because we have a lot of people after they get an ACL reconstruction. It's very often that we see them getting a patellar tendon pain after the rehab if somebody's very aggressive with their quads in the beginning. So we wanted to see the literature for that too, so that we can also somehow help people rehabbing ACLs. And it was very interesting to see the results because the squat, the single leg decline squat, which is the exercise that everybody used to do, is the first exercise in the first day for the patellar tendon with the eccentric program, the Alfredson's classic eccentric program, was the exercise with the highest index, the highest load of all, even comparing with single leg jumps, single leg maximal vertical jumps, running and cutting, changing direction. Nothing was able to beat the single leg decline squat. So it calls our attention to the fact that this is the exercise that people were giving patients in the first day, and they have a pain of 8 out of 10. And if our whole premise is to gradually build load tolerance, it doesn't make any sense for us to start with the exercise with the highest load in the very first day. So the study was important in that sense specifically. When I presented those results in the World Conference of Tendinopathy in Valencia a couple years ago, that was one of the things that stood out in the presentation, and people were actually talking about that. And I showed a systematic review that people are still recommending eccentric exercises. It was very recent from a group that was there. And I actually got them thinking. I say, we know that it's not load, it's not the type of contraction that matters. I mean, everybody here on the audience, raise your hand who uses the single leg decline squat as their only intervention. And like nobody lifted their hands. And I'm saying we give the clinician, the young clinicians, mixed signals when we tell them that the eccentric program is the best intervention, when nobody here, the biggest experts in the world, uses that as their intervention. So we should be very careful with our systematic reviews. When we publish that, we have to talk about loading. Loading is important. It's not a type of contraction that matters. It's the time under tension, is in the amount of intensity, the exact intensity of load that we are applying to the tissue. It's not a type of contraction. So yeah, the study was important because it called attention to a very important specific topic that was still being disseminated as the best practice, and it's far from what people are actually doing in their clinical practice.
Mm. Is that, I know you said earlier you use that single leg decline squat as like the load provocation the next morning,
Yeah.
and that's something I give out too. But I feel like if they keep doing, I sometimes just tell them, just get a feel for your symptoms in the morning, walk around and go upstairs or something. Because if it's really sensitive, I'm like, maybe it's not that good. I've had people say because of that loading index, it makes sense to use it later in rehab as like a higher stress thing. And that does kind of to me, I've just been like, it just tells me I'm not going to use it because it's like it loads the front of the knee so much. And what are you getting back other than it's just a really sensitive thing?
Well, one thing that I will say is I think it's useful for people who are very, like, I had an athlete who was a parkour. Is that how you say in English, parkour? The guys that jump from buildings?
Parkour, yeah.
Parkour. Yeah, they jump from buildings. These guys are under a ginormous amount of load in their tendons. So we saw that we have a figure in the paper too, where we compare the different squats in relation to the load that you have when you do gaits, just walking, and running. And what we saw was from all the squats that we tested, the Spanish squat, the sumo squat, the Bulgarian squat, no squat came close to the load of the running, but the single leg decline squat was higher than running. So if I want to prepare this guy for like really running deceleration, jumping from a building, I need to like prepare him for a very high amount of load. So for this guy, it does make sense. But for your average Joe that comes to you, your guy that plays sports in the weekends, even for professional basketball players, I don't think it makes all that much sense. We have a whole possibility of exercises that we can use with external load. I don't really like the idea of using that, except that it can be performed at home. That's one of the advantages. So for somebody who doesn't have access to a gym, it does make sense to use that in the advanced stage. So this guy can't have like very big external loads to do the exercise. So for this guy, it may make sense, but now I think it's the exception. It's not the rule, not at all the rule anymore.
Mm-hmm. Okay. Last one I got for you here on this whole kinetic chain thing, because I think we talked so far a little bit about the landing mechanics, but the getting the calves, quads, glutes with that patellar quad tendinopathy, kind of addressing everything. I feel like I have a lot of physical therapy friends, and not to hate on physical therapy, I guess sometimes, because it's like the tendon rehab for like a patellar tendon. I went through it myself. It was very bad. Not loaded enough, not addressing all the areas you need to address in the strength work. But then let's talk about going back to plyometrics or going back to store and release, and it's like that is even worse. Like there's no guidance there. So for you talking about working that kinetic chain, like having that ability to dissipate loads through the calf, through the knee, through the hip. What are you doing in that store and release phase? Is it something where someone needs a coach there to watch how they're doing everything?
I would ideally want to have that too. I mean, it's not the reality of the majority of people to have like a strength and conditioning coach, to have somebody like an athletic trainer to actually help them progress through the advanced stage. So here in Brazil, there's the profession of athletic trainers doesn't exist for you to imagine. It's just sports physical therapy. So we have to know what we're doing in that advanced stage as well. But we have physical educators who are personal trainers who we often discuss these things, biomechanists that we discuss these things so that we can actually have a general idea of how to progress better the advanced stages. But it's kind of tricky. Yeah, it varies a lot. There's no guidance in the literature. We have that study by Igor Sancho and Spain that did a progressing of plyometrics for the Achilles. We don't have the same for patellar tendon. So what I tend to do is I progress similar to what he does there. We use the knowledge that we have from strength and conditioning coaches. I do like to do plyometrics, not just focusing on the knee, but I also do a lot of plyometrics focusing on the ankle. And I do some plyometrics like explosive strength, not just reactive strength, but also explosive strength, doing bigger range of motion with higher loads as well to prepare them gradually to what they want to do. We try to decompose the actual sports movements that they need to do and prepare them gradually to come back to that. with the plyometric exercises, the reactive exercises that we do. But like you said, there's not much literature on that, and that's also a literature gap that we need to fill in the future.
Hmm. That um, I think it was Carr and someone else was a lead author. They had that study on patellar tendon, and one group did loading 3 times a week, and they were not able to play their sport. And then the other group was doing the loading 3 days per week, but it was like they did the pain guided activity scale,
Yeah,
where like
it's Carr.
um yeah, okay. Because I've used that to give guidance on in-season rehab, because I so many people with patellar tendon, they're basketball players, or for me, basketball players, and it's like there's no off season, and they're always wanting to play. Where do you stand with that? Where do you give that advice of like you need to be take off sport, or do you think there's benefit to staying in sports? Where do you stand with that?
Well, that's a great question, and we try to always keep them in sport if we can, but sometimes we can't. I mean, I have a very big challenge treating runners here in Brazil, because I like to treat triathletes, because you have swimming and you have uh, bicycle, you have cycling that you can actually do while you're not loading your Achilles. You're not. We can play around with those loads and keep the guy actually physically active, doing what he loves to do. But with runners is a big challenge, because they don't want to stop running. They have their spreadsheet. They have to stick to the spreadsheet. They want to keep their miles, and they just don't want to offload the tendon. What I tend to do, the rule of thumb that I usually use is, what is your pain like the next day? So you ran like 10 miles. What's your pain the next day? You played your game. It was a competitive game, very tough game. How was your pain the next day? Well, my pain is 4 out of 5 out of 10. Okay, you can keep that intensity. With running, same thing. If the pain is below 5 in the next day, I tend to allow them to do. I ideally want their pain to in the next day to stay below 3 out of 10, but that's kind of tricky too, because a lot of people will lie to you. They will say that the pain is different than it actually is, because they want to keep playing. But it's a big challenge. But in general, I try to keep them with the intensity that their pain is not too severe in the next day. So for runners, if 20 miles running will give you a pain that is very severe in the next day, but if you run 5 miles, your pain in the next day is manageable. So you keep running 5. You can play with the pace. We can avoid, for instance, uphill running. We're gonna maybe increase your step rate, so you decrease the high loads in your Achilles tendon. There's a study that showed that too. If you increase 5%, you decrease the load in the Achilles. Maybe you give them a shoe that has a higher drop, so you keep their calcaneus a little bit elevated in the beginning, but you keep them playing. The idea is to keep them doing what they love to do, because in my experience, that improves the adherence to the intervention, in addition, versus completely saying you have to stop everything you're doing, because that's kind of lazy. Everybody does that. If you go to any physical therapist here in Brazil, they'll say you have to stop everything you're doing, and they don't want to stop what they're doing. I mean, if we sit down and find a way to keep them doing what they're doing with just a few modifications. I have to have days off. That's non-negotiable. That's something I tell them. I know you think you can do every day. You cannot do every day. If your tendon is going to change, it's going to adapt to the stimulus that we're giving, you need to rest. So we're going to make sure that you have one day off at least after your very heavy intensity activity of the week. So we try to keep those 36 hours that the Danish group emphasizes, that are important for turnover, for the positive turnover of the tendon. So that's kind of how we do it. We sit down with the patient, we look at their calendar, we make sure that we have loads in one day, and the next day they have not high loads for the tendon. So they can, it's not that they're going to rest completely. They can do something in that day. But for the upper limb, they can do something that is not going to be a heavy load for the tendon, so we have time to adapt. That's pretty much how I manage things like this.
Hmm. Okay, what new piece of research are you working on right now?
Yeah, so I'm very proud of the study we're going to release in a couple of weeks. We have a PhD student defending this afternoon, actually. So we compared two groups. One group did the heavy slow resistance protocol for the patellar tendon, and it's a randomized controlled trial. And the other group did what we call the kinetic chain intervention. So we did what I just told you, an intervention that addresses the calves, it addresses the glutes, but it also loads the tendon progressively. And we only have, I can't actually share all the results with you because it hasn't been peer reviewed yet. It hasn't been published yet. But what we saw was in the long term, the group that did the kinetic chain intervention was better than the group that did just the heavy slow resistance protocol. So interesting stuff to look forward to is exploring more, adding kinetic chain interventions to your athlete, not just focusing on your progressive loading, because in the long term, it does seem to be a better approach.
Okay. All right. Rodrigo, tell people where they can find you.
Oh, Jake, this was a pleasure. I've been a fan of your podcast for a while now. I've been listening to Peter Maliaras and Hazel Screen and Karin, and it's an honor to be here. People can find me in my Instagram mostly. I have a page that I dedicate to knowledge translation, mostly in Portuguese. So it's your opportunity, people, to learn Portuguese too. No, I'm just kidding. You can just hit translate on Instagram and it translates everything. I try to do knowledge translation there. I also have an account on Twitter, but it's not as active as my account on Instagram. So if you look R Scattone on Instagram, you can find me there. I'm planning on having a YouTube channel next year too. So releasing videos. We're very concerned about the knowledge translation now because that's also a big challenge. It doesn't mean a single thing if you publish a fantastic paper, but people don't hear about it. So we're focusing on knowledge translation as well. So yeah, this is how people could find me.
Okay, perfect. Thanks for coming on.
Yeah, it was a pleasure. Thank you.